the advanced movement surgeries using different implants in an advancing sort of an age. So rotator cuff basically is a combination of capsule, ligaments, tendons. They actually converge in one to a single sort of a bone. Now, this was a very interesting article that I recently, Mr. Shah was generous enough to actually buy this article for me. It actually tells us that how the tendons, ligaments, and capsules of the rotator cuff, they actually are arranged into the proximal part of the humerus. And this article was actually written in 1992. And so far, the literature that I have read, I found it to be a very state-of-the-art sort of paper in order to understand the anatomy of the shoulder. So how does actually the anatomy converge onto the humerus? Now, as in this diagram, you're able to appreciate that the rotator cuff is actually encircling the whole part of the proximal part of the humerus, but there you need to understand that there is a structure which actually goes inside or in between your part of the rotator cuff, that is the supraspinatus and the subscapularis, and that structure actually goes from extraarticulars, enters in, and goes into the intraarticular part of your humerus. Now, whenever actually talking the most now out of all the rotator cuffs that are actually there anatomically, which structure has got anatomical most importance? Well, that structure, according to studies, according to the presentation, pathology point of view, the most important structure is the supraspinatus, and the second most important structure is the subscapularis. Now, if you're trying to understand anatomically how the supraspinatus actually is present and what are the structures, you need to understand the osteoligamentous tunnel that the supraspinatus has to pass through in order for it to reach from the superior part of the glenoid into the proximal part of the humerus. So this structure, you can see, you can appreciate that there is a acromion and there is a CA ligament attaching it to the coracoid, and in between this tight space, the supraspinatus actually travels from the supraglenoidal fossa into the proximal part of the humerus. So again, when you're actually talking about the supraspinatus, this is the acromion, and you are able to appreciate that the supraspinatus attached on the superior part of the proximal part of the humerus, and above that there is your the supraspinatus bursa or the subacromion bursa, which is again anatomically has got very much importance in whenever you are actually looking at pathologies and whenever you are actually going and managing these sort of structures of pathology inside your rotator cuff. So the structures above the rotator cuff and the structures below the rotator cuff, they both carry very much importance anatomically, and you need to understand that what are the pathologies which actually are taking place. So the structures above the rotator cuff become the bursal side, and as you can actually able to appreciate that there is a subdeltoid bursa which is present, and which is one of the pain generators as well, plus a very protective structure which actually prevents a lot of your problems, including impingement and secondary related thing. And the structure and the part of the supraspinatus which is inside this becomes the articular side of the rotator cuff. Again, anatomically, it has got a very much important because of the fact that the various pathologies actually occur in this sort of this part of your supraspinatus. Now, this is a diagram to actually show that which part of the humerus that you are actually able to see that exactly on the humerus. That is, you see that there is a subscapularis attached on the anterior part. The supraspinatus attached on the top part, and on the posterior view, you can see that these are the anatomical bone marks, landmarks in which you are actually able to appreciate. And you need to understand the importance of these tuberosities in you're actually looking at your reconstructions. You actually have to put them back onto their anatomical parts in order for them to function in a normal sort of a fashion. So looking into the sagittal section, this is the section that you'll actually be able to understand that in front you will be able to see just below the coracoid you have got the subscapularis, and this actually space that forms in between the subscapularis and the coracoid becomes the subcoracoid space. It forms a bursal space inside, then becomes your long head of bicep, which actually becomes into a structure which is a rotator interval, the supraspinatus and the infraspinatus. So this is this diagram is basically from the paper that actually I have actually showed in the front. This was actually a dissection which actually shows that how the actually supraspinatus, all those muscles, they converge into a one single structure and then they encircle or enclave all of your proximal part of your humerus in order for it to actually function properly. Now, this space, which actually forms in between, if you splay out these muscles, this is the space in which you actually, your long head of biceps actually crosses and traverses, which again parts are very much important part in whenever you are actually understanding or recreating your anatomy in terms of your advanced sort of a reconstruction. This space is basically an interdigitation between the capsule, the ligamentous muscles, and it is a complex structure, as you can actually able to understand that it basically forms an encircling sort of a phenomena in which your long head of biceps is actually traversing. So this is again another diagrammatic representation of how all these muscles actually converge onto a proximal part of the humerus in order for it to actually give it an anatomical sort of a structure. Now again, this is the intrasynovial part of the long head of biceps, in which actually it anchors on the superior part of the glenoid in order for it to become in an intra-articular part of the structure. Now again, when you're looking at the anatomy from arthroscopic point of view, this is what you actually see from the posterior portals. You see that a shiny structure which is in front of you, just below the rotator in your interval is the subscapularis in the humeral head. Then again, this is the long head of biceps, and after the long head of biceps, if you actually follow more laterally, you'll be able to see the supraspinatus, which is anchoring. And in order for you to visualize all of your infraspinatus, you need to actually rotate your arm internally in order for you to actually visualize all the bare area in which your infraspinatus is actually attaching into. So coming to the vascularity part of the view, what is basically the blood supply? It is actually supplied by the axillary artery. It actually it branches into thoracochromic artery. It actually divides and provides the blood to all of the adjacent structures of the rotator cuff, and the subscapular artery is a separate branch which actually provides the subscapularis out of it. Neurology point of view, the spinal roots are actually involved, in which the structures of it is supplied from the C5 to T1 level. The suprascapular nerve is actually it provides the motor branches to the supraspinatus muscle, and the axillary nerve actually provides the motor branch to the cuff and the deltoid providing adjacent to it. So the subscapular nerve arises from the posterior cord and actually divides into upper and lower sort of nerves to actually provide the blood separate nerve supply to the subscapularis muscle. Now this concludes to all part of the anatomy of the rotator cuff and the adjacent structures and the blood supply, the nerve supply regarding that. So this actually concludes the first part of our talk. Thank you very much. Now, sir, back to you for the further progress of the talk.
So I'm going to try to unmute everybody because I think I've got the control now. So you guys can ask questions if you want. Anybody want to have a question?
और कितनी इधर कितनी लगेंगी फ्लोर पर?
Sorry, please. Yeah, can we make it serious, please? Yeah. So can we ask questions? Anybody wants a question?
I think I'll be the lucky part because of the fact that I think there will be no questions as far as anatomy is concerned, because this is something.
There are a few questions I have. You can't get away just like that.
But still,
First question is not a question but a comment. The biceps tendon is a very important structure. Everybody must understand that for arthroscopy and for people who are doing shoulders, it actually demarcates the interval. We know where the supraspinatus is and we know where the subscap is. So it tells you where the interval is. Plus, because of the way it is attached, it is important to understand that either you reattached it or you cut it, but you can't leave it on its own, because if you do, it is a painful structure. Plus, the most important thing is the biceps tendon, although involved into the glenoid, is attached to the posterior labrum. So when it pulls the posterior labrum with it also. So it's not just the biceps tendon, but the posterior labrum has to be looked at because it is part of it. That's the first thing. Okay, a comment. The question to Sufyan is how important the infraspinatus and teres minor are, because you mentioned quite a lot about the supraspinatus and the subscap. There are two other muscles. So what is the importance of infraspinatus and teres minor in the anatomy?
Well, the infraspinatus and the teres minor are basically the external rotators, and actually they are attached on the posterior most part of your humeral head. The anatomical appearance and the anatomical structure that the variants that actually get into that, these structures are actually not involved in many of the pathologies, most commonly because of the fact that the coverage that the span of the area that they actually get and they are attached to, mostly you actually tend to come across very little pathologies related to the the minor and the infraspinatus muscles. So to me, I have only seen approximately I think only one pathology which is actually involved isolated infraspinatus sort. And what I understand from anatomical point of view, that why infraspinatus is not that much involved is because of the fact that the blood supply that the infraspinatus has got, the anatomical position it has got, because you see that the supraspinatus has traveled into an osteotendinous sort of structure, plus the blood supply of the supraspinatus region is actually comes into a watershed sort of an area in which it is not very much actually vascularized. So this is what I understand from infraspinatus, and as learning is an evolution sort of phase. So is there any better explanation?
The infraspinatus does not tear on its own, as you said. I think that the anatomists have got it wrong. The supraspinatus infraspinatus is one structure. You know, if you look at the anatomy, the way you look at ultrasounds and look at MR scan, it is basically same structure with nearly same blood supply. However, on its own, isolated, I've not seen it, but I've read it. The other thing is the importance of the supraspinatus is its function. The supraspinatus predominantly just works by putting the ball back into the socket. And that's why the pathology is more common, more prominent if you have a problem with the supraspinatus. The other importance of infraspinatus is if you cannot repair a massive cuff tear, and if you don't have an infraspinatus, then you can't put in what is called a superior capsular reconstruction. It is very important to have the infraspinatus working or be present to put a superior capsular reconstruction. Otherwise, it is totally not working. Of course, the subscap you mentioned, the importance of subscap is that you cannot do anything else if you don't have a subscap. So it is key to have a subscap. Okay. So if anybody else has a question, I've unmuted all you guys, but nobody wants to participate. So leave us up. You want to ask a question?
No, I'm fine.
You're fine. You're looking very good with all these colors and everything. I thought you were flying in a plane and you're taking part with us from a plane, but no, you're not. Okay. So if everybody's happy, I'll do my talk and then we can ask more questions, yeah?
Sure.
So I will show you, if I can, my talk. Unfortunately, or fortunately, this is a talk that we've already done a few times, but I've just modified it for today's talk. Okay, so we've been enlightened by Sufyan on anatomy. I was hoping that Tariq would do portals, which is partly important because portals are important for arthroscopy. The key thing to understand about portals before I do my talk is that you have to be in a straight line to assess whatever you want to do. So portals are a la carte, which means you can make a portal wherever you want to. There are standard portals and there are portals that you make. But the key is the instruments are straight and the arthroscope is straight. So you can only work if you have a portal that can give you directly access to where you are in a straight line. So this is a short talk. I've modified it today, like I said, on how I do cuff repairs, okay? So it's very important. You must understand that I don't live in Pakistan, but I have got a lot of love for Pakistan, and this is what I do, and I enjoy doing these talks and education for Pakistan, okay? So before you do anything, you need to know what's wrong. So I'm fortunate enough, and I'm hoping Sufyan said that he will have a ultrasound soon, but I have an Arthrex, a portable ultrasound, which I can scan, and once I've scanned them, it tells me whether the cuff's torn or not. Sufyan was here, so we had a big, huge giant of a structure, which was like a big trolley. But this is now an advancement. It is far better than all the systems that are around. At least in my hands, I can diagnose the cuff tear. So once I've diagnosed a cuff tear after the patient's symptoms have told me that it looks like a cuff tear, I will then classify it, okay? So if you can look at this particular picture, you have the subscap, a separate entity. You have the interval that Sufyan showed you where the bicep tendon comes in. But if you look at anatomically, the whole thing looks like a straight structure, and that's the infraspinatus and supraspinatus together. right? But anatomically, we can classify them by the Habermeyer classification into a zone, which basically involves bicep tendon pathology and subscap. Zone B, which is supraspinatus, which means that the ball is not going to be in the socket, and therefore it is going to be going higher up, and therefore if you're not got a round circle in a round socket, then you can't have function. And then zone C, we put in the infraspinatus added onto it with the teres minor. But if you have such a big cuff that goes around from here to here, then it's very difficult to do any repairs. Most often you'll have to do something else with them. Like, okay, so I do first this, I classify them with my ultrasound and see where my tear is. Then next thing is I use the cold feet classification to tell me whether I can do anything with it. So there's a orthopedic classification is the good, the bad, the ugly. So the small is the good one, medium is the bad one, the large and massive are the ugly tears. Okay, and arbitrarily they are divided by 1 centimeters, 3 centimeters, 3 to 5 centimeters, and 5 centimeters and above. So this massive tear is in a classification where most of the time you can have to augment them or do something else with them. Okay, so if you look at the picture, there is some attachment still left in the small tears. The medium tears are just about separating, and the large tears are separated from the tuberosity. The massive tears are nowhere to be seen, and they're retracted, and you can't bring them together. Okay, so then what I do is I do an MRI scan of these patients. So first of all, I clinically examine them, then I scan them, then I classify them, then I need to know if I can repair them or not. If they're more than 5 centimeters, then I know I can't repair them. And the second thing I do is I do an MRI scan, which I look at the tunnel that you've been so nicely shown, the supraspinatus and the infraspinatus. These two muscles I look at, okay? And the mild one I can repair, the moderate one I can scope and try and repair them, the severe ones are irreparable. It's depending on how much fat infiltration they have and what is the function left. So again, going back to them, clinically, ultrasound, then MRI scan, okay? So I have now an option where I have patients who have cuff tears, right? The key is to put the ball back into socket. If you put the ball back into socket, it'll work. There are various ways of doing it, okay? There is magic also that I preach, and Sufyan has seen it. It's called the balloon or the superior capsular reconstruction. But we're not going to talk about magic today because we're going to talk about the simple cuffs, okay? So this is not the talk that we're going to do today. We're going to talk about how I repair them, okay? And this is what we call, it is called the toe repair or the transosseous equivalent repair. Incidentally, I have, Sufyan read a paper today, this morning while waiting for this. I will post it on the sports forum, but it is telling that the mini open is far better than doing an arthroscopic repair. Okay, the results of the mini opens are far better than arthroscopic, but I will share it with you later. So anyway, I do what is called a transosseous equivalent, which means you have to put the tendon through or touch it to bone. So this is what it looks like before, and this is what it looks like afterwards. This is what I use. I used to use this hardware. I'm now gone all R6 purely because R6 is going to do sponsored education with us, so therefore we've gone all R6. But I used to use the striker equipment. The striker equipment is basically, there is a hole in the anchor, so the peak zip hit it and it will just go, and then we have these lateral anchors which will bring the sutures on into the anchor and bring them together. I have a 6-finger knot pusher which is here. I have a suture passer, and I use a cannula as everybody else does. Okay, I have a fantastic table. I do the B-chair position, and this is how I do it. I do them B-chair most always. I've never done a lateral position, but a lot of people can. And for me, the anatomy is totally reversed. I cannot appreciate it, but if you're used to doing lateral, there is no bad thing about it. So these are portals that are mentioned and are very, very rigid and very, very standard. So if you look at it, this is your coracoid, this is your posterior lateral acromion, and I use a finger breadth below and a finger breadth middle to find a spot, which is the posterior portal. For the lateral portal, if I'm doing a cuff repair, I will do a central portal. However, if I'm doing just a decompression, then I will do a very anterior portal to take the acromion out. And I will decide on these portals once I put the camera in. I have a divisor portal, which is for my cuff repairs. I can use this portal to go in, put a suture, and come out again. However, recently, both R6 and Striker have come with suture graspers or suture wipers, which are far better, and they've got a nearly 100% success rate. So I've stopped using this portal, but that is a very good portal if you don't have that instrument to use. Okay. So these are some pictures from my scopes that I've done recently. So I've had a look at it, and I've seen that the cuff margin is here and it is repairable. So I will then clean the tuberosity. I will then shave the tuberosity to bring bone onto it. I will put my portal in there, and through the portal put in my first medial anchor. The medial anchor will have sutures in it. So once the medial anchor goes in, the sutures will be left. I will then separate the sutures into two different colors so they match each other. This is called portal or suture parking, where I take them out of the way and leave the ones that I'm working with. If you put everything in there, then it becomes a spaghetti junction. So I park my sutures out of the way so I can work with only some. You can see this, I've come anteriorly and taken the suture out and parked it out of the way, so I've got now one suture a minute. I will then use my scorpion, bite the cuff, and the suture will pass through it. I will make a mattress suture and bring it together and tie it. Okay, so this is my mattress suture. You can see the mattress suture, and the mattress suture is being tied, and when I tie it, I will then take it, park it outside, and bring the other suture into place. I've now taken the white one out, or the tiger suture out, and bringing the blue one in. So this is called parking. It is very important to learn how to park sutures if you're doing cuff repairs. Okay. Once I've done that, I will do the second suture, and there is a technique that I will show you in my video that the sutures get entangled. So what you do is you catch the suture and go underneath it, the first one, so then you can actually be out of your way. The video will explain it anyway. So I've got another mattress sutures, and I've tied them by my 6th finger knot pusher. So now I have got a footprint which is now touching bone. Okay, so we've done that. So in the next position is now to alternate the suture. You take one blue and one white suture, bring them together and pass them through my lateral anchor. And when I pull it, it goes through the anchor, and when I tighten it, it'll bring it together. So this is a bit complicated on these pictures, but the video will explain everything. Okay, so now I have alternate blue and tiger sutures together, and that's what the end cuff result looks like. So it is a good cuff. It was movable. You could free it, and you can do it. I think my video comes next. Yeah, there you go. So if you can see it, this is my scorpion. I have a striker one and an Artex one. It will bite the cuff. Okay, the suture is passed automatically through it. And the needle will bring the cuff, and then it grabs the, and you can see this, if you can understand this, that you have to go above the other one to untangle it. So now I've got both sutures as a mattress. I will pull it and tie them. So once I've tied the sutures, then what I will do is I will take similar colors or different colors and take them out of the way. This is my lateral row anchor, which has got a loop to pass the suture through it. So the key is that it brings the cuff onto bone much nicer. So what if you see this, you keep hitting it, it will go deep, buried in it. And once it's done, you can see when I tighten the anchor, the cuff comes down. You can see that in the video. Yeah, you can see that very clearly on this particular video there. And the same, the other one, we do I do 2 or 3 lateral rows also. So I've brought all the same colors together, or alternate colors, depending on how big your tear is. So this is your lateral row anchor. It is all there's no making holes or drills or anything like that. I just take the anchor and hit it, which is great, isn't it? We all like hitting things. So again, you watch closely. Once the anchor is deployed, you can tighten the tension on the cuff onto bone. This is the key part. This is probably the only anchor that does it. Is the striker system. Nothing else. You can see how the cuff is coming together, and then we cut the suture anchors and we end. However, that's not completely where cuff repair is going these days. Okay, so you must understand that although we are very good with anchors, it looks like it's going to be the past, not the future. Okay, and I keep making these statements. A lot of people think that I'm being funny, but it is true. The future of joint replacement is not joint replacement. Certainly the future of rotator cuff repairs is not rotator cuff repairs. Okay, so there is a new thing that's been in the market, and it's got a lot of evidence with it. We used to do PRP, now PRP with tendo PRP, which means they have added something onto it. And if you have small to medium tears, if you inject them, you don't need to repair them, they will heal. There is enough evidence. I have some references here. I'll copy and post them to you, and we'll see what happens, okay? So this is called tendo ACP. And, you know, funny enough, the tobacco guys have found a use for their tobacco plant. The tobacco leaf has got the same recombinant structure as collagen type 1. So they take it and they mix it with the PRP, and then it heals in the shape of the collagen. It makes a scaffolding, and then the tendon heals. So this is totally fresh, totally latest structure, I'm telling you, and it's on the market. So I have started using it. I have an experience of 3 patients now. I will tell you in about 6 weeks, 12 weeks, what is happening to them. But apparently that's the way forward. So the small and the medium tears you don't repair, you just do a tender ACP injection into the shoulder. And this is how it's done. You do a PRP, and then you have the powder of the tender ACP. You mix the two together, you agitate it, and you have a structure that you can inject into the shoulder. So the surgeons are going to be far and few in between. There will be a lot of older physicians in the future. That's what's happening. Okay. Then there is gene therapy. You can have what we call is nano surgery, and you have tiny nanobots that you can inject into the shoulder, and then they will actually make cuff for you by remotely controlling them from a computer. And this is a very interesting picture. You know, this is a artery with an arthroscopic plaque that before they took the plaque out, they used the nanobots to make a guitar into the artery. So if you can do that, you can certainly reconstruct the cuff. Okay. So my question is, you know, we all enjoy doing all these fancy portals and injection, suture channeling and parking. Is it going to be fun? You know, I enjoy doing this. I think it's going to be very boring if I've been told that all you have to do is inject into somebody's shoulder and get better. Okay, so that was my short talk, and open to questions. No questions. And everybody's stunned, is it? You have no questions? Oh, sorry, yeah.
Yeah, sure. Go ahead.
Assalamu alaikum, sir. Very nice presentation, very informative. So I have a question from your latest advances that you showed to us. It means like very soon the orthopedic surgeon will be of no use, and everything will be on gene therapy. Same with the arthritis, we're going to have a gene putting inside.
Yes, it's true. It's
Sorry.
true. But you see, the key is for us to be clever enough to be before everybody, ahead of everybody else. If you recognize that this is what's happening, you need to learn and do it rather than stay away from it, isn't it? So, I can't hear you anymore. So the key is that for us as an orthopedic surgeon, we need to be aware of the advances. You know, it is a reality. That's the key. Don't learn it, then everybody else will learn it and you will be left behind. There will still be a role. I don't think so that completely injections will happen in my lifetime, but you youngsters will have to see this and have to play with it and tolerate it.
So, sir, my question is that what for now, if we are repairing the cuff or something like meniscus, you think this putting an additional augmentation of PRP will be an additional support and more effective, or rather than doing simply and repair and come out? What you're saying about it?
Okay, so I've told you in Pakistan that I am a gambler. I will do everything that will help my patient. So the reality is that in biologics, you have to have a scaffolding, you have to have a mediator, and you have to have a generator, right? So your platelets will create stem cells for you. So your scaffolding is your repair, right? So if you do a repair and you actually put PRP in it, there is now evidence to support that they do heal well. So yes, you can do a cuff repair, or you can do a meniscal repair. Even in an ACL repair, you can do it. You can augment it with a PRP. That is what evidence suggests. I sometimes augment my cuff repairs with a balloon, right? Purely because a balloon came before genetics for me, so I do that, and it works for me. However, there is now a lot of evidence to support the fact that if you augment your repairs with PRP, they do well, and they do heal quicker than not doing it. Although not doing it, the end result will be the same, but to get from point A to B with PRP, it is quicker. So एक साल के अंदर जो है ना दोनों का रिजल्ट आउटकम बराबर होगा. लेकिन अगर आप उसके साथ PRP से augment करते हैं ना, तो the outcome will be quicker than just doing it without the PRP augmentation. जी सलीम साहब.
So is there any role of allograft for the repair of massive?
So the short answer is no, right? But it does not repair cuff. It will repair a capsule for you, right? So there's two different things: capsule and cuff. So if you put an allograft in it, there will be no function.
Okay.
It will just be a superior restrictor, and then it becomes a capsular reconstruction, not a cuff repair then. Yeah,
Okay.
yeah.
And I read in one book, they said they approximate the anterior and posterior cuff on the top. Do you think, does it work?
I'm sorry, I didn't hear you.
You know, in rupture of the supraspinatus,
Yeah.
they approximate anterior and posterior cuff on the top of the shoulder. Does it work?
Approximate means we pull it down.
Yes.
Yeah, yeah,
Oh.
it does work because it's retracted. So you have to push it and pull it and free it and bring it together. If you can do the cuff repair, that's the best way of doing it. That's the best way of doing it.
Okay.
No more questions? I think I have recorded this also, Sufyan.
Okay,
Sir,
that's very nice.
Basically, I'm a shoulder learner and a knee surgeon. That's what I have been giving this.
You've been giving PRP.
Anyway, sir, one point.
Yeah.
Well, yeah, PRP. Yeah, still I'm just on the same PRP. So now the point is that it will going to help us. Fine, we got this message. So now we are putting the fluid inside the joint to repair our rotator cuff. So when is the time that we have to inject the PRP? I mean, the fluid need to be evacuated from the joint, and what is your technique?
Okay.
How to put PRP to get the augmentation?
Okay, so the fluid is already there doing the inflammatory and reparative process for you. So it is a good thing, it's not a bad thing. However, if you inject it into the joint, it will be diluted. So that is why I have an ultrasound machine given to me. And the reason I've been given the ultrasound machine is to inject into the supraspinatus cuff directly after I've seen the tear. Okay, so it has got to be in the tendon. It can't be sprayed around it. And it's the same way with the ACL when you're doing it or when you're doing the meniscal repair. You have to inject it into the repair in the meniscus or in the ACL joint where the footprint is, not just spray it inside, because it won't work that way, like I said. So one of the reasons that I've been given the ultrasound machine is that I can inject directly into the cuff under vision. So where the tear is, I'll find it, and then I'll localize it with my needle and I'll inject it. So there are some surgical skills involved. It's not totally orthopedic physicians, but yes, you have to not put it into the joint, but into where the repair is or where you want to heal. Yeah? I can see you. Yeah, Kazim, go ask your question.
Sir, sorry, it's mean that per operative you don't inject PRP. It's been after a week of repair that you plan to inject PRPs like that?
So the thing is, there are two ways of doing this. The first way is you decide not to operate on it. It's too small a tear. It's less than 3 centimeters or less than a certain limit, and you inject it directly without repairing it, ultrasound-wise. Okay? But once you're repairing it, you inject it at the same time.
Yeah.
So I was saying that, Sufyan, I think
that's got your point.
I will see if I can put it together and I'll post it to you, and you can look at it and save it. But yes, I think it was a good effort. We had about 9 people in it today, or 7 to 9 people at this stage. So not bad for a start. Hopefully we will see if we can get a knee next time. So Kazim, next time you're going to prepare something. So one thing by the end of January or beginning of February, we'll do another talk. We can do one in between if you want to. Everybody wants it, but next time it's knees. It's okay?
One thing which I want to ask, how do you compare between open?
So we can have our
Sorry?
How to compare open technique versus...
I can't hear you, sir. You need to speak a bit louder.
Sir, this is Dr. Tahir Yunus.
Can you hear him, Sufyan?
Hello?
Yeah, I can't hear you, sir.
Yes, sir, I can hear him. He's basically asking for comparison of open repair versus an arthroscopic repair. You mentioned in your beginning of the talk that there is a paper that actually shows that
so
mini open is
I will share it with Sufyan, and if you can ask Sufyan, or if you can send me your contact details, I'll give you the paper. The open repair, and which is called a mini open, not an open repair. The open repair, they used to open the whole thing and repair. It's called a mini open repair, and what it means is that you have to localize your tear with a needle. You do an arthroscopic tidy up and clean up, then you localize the tear with a needle, and then you open just a small area around the needle that you put in, and you find the cuff and you repair it. The re-tear rate of mini open is less than 3%. The re-tear rate of an arthroscopic repair is more than 15%. However, the Arthroscopic Society has accepted that 15% re-tears is a standard in arthroscopic repairs. So the mini open repair is much better in long-term re-tears. However, in a year's time, the ones that do well both at the same time. So it's a complicated paper. It doesn't mean that we stop doing arthroscopic repair, but what it says is that a good mini open repair is as good as doing an arthroscopic repair. That's what it says.
Thank you. Thank you, sir.
Should we close the meeting, and when we'll see how we get on in the future? Okay, thank you very much for joining us. Thank you very much.
Thank you.
Yes. Thank you, sir.
Thank you very much.
Sir. God bless.